Hey guys, thanks for joining me again for another episode of my YouTube channel, Long Live the Brains. Today I've got what I think is a very important video for you, and it talks about how different people may view neurodegenerative diseases from different perspectives. So I talk about the physician perspective and some of the pitfalls that can oftentimes happen in the context of a short appointment, and then also how friends and family may view individuals that have neurodegenerative diseases. And I talk about how we can kind of reconcile these two conditions that may be almost kind of polar opposites. So I hope you enjoy.
What can unfortunately all too often happen when patients with neurodegenerative diseases, arguably the most complicated diseases there are, Parkinson's disease, the most complex disease, period, come into the office. Now, these are complex diseases, and because of that, they can affect many different aspects of your health. Take Parkinson's disease, for instance. We put a big focus on the motor diseases, the motor symptoms, and yes, that's what we see, most commonly, like when you're walking down the street. If you saw someone and you suspected they had Parkinson's disease, it would be because you saw, their tremor or reduced arm swing on one side or their shuffling walk. But there are so many other aspects of Parkinson's disease that we've talked about, autonomic dysfunction. You can have urinary problems, bowel problems, sexual dysfunction. You can have sleep dysfunction with REM sleep behavior disorder. Mood dysfunction is common, such as depression, very, very, very common in Parkinson's disease. So it can be so difficult to get all of these things covered in the confines of a short follow-up appointment. And so that creates a large temptation, and I can speak from personal experience, for physicians to take sort of a checkbox approach and say, okay, do you have A? No. Do you have B? Do you have C? Do you have D? Okay, you've got that. Let's dig into it a little bit more. And before you know it, the patient becomes a collection of symptoms rather than a human being. And as physicians, we have to fight that. We have to remember that, even though we're always on a time crunch, the needs of the patient come first. Now, on the flip side, family members, loved ones of an individual with a neurodegenerative disease may sometimes find it difficult, whether conscious or subconsciously, to recognize that symptoms that are a manifestation of the disease are just that, rather than, say, changes in personality or something that person actually has control over. A good example is Alzheimer's disease. Early on in the disease, individuals may be forgetful, but as time goes on, that forgetfulness worsens and worsens. And it's not that they're just being absent-minded and don't care anymore. It's that there's an actual pathologic process going on that's affecting the brain circuitry that's absolutely critical for memory. It makes sense, but when you're actually talking to a family member with Alzheimer's disease, it can be difficult to remember that. So that's a little bit of a segue into me talking to you about a different cause of dementia, and that's frontotemporal dementia, which is really kind of a group of different dementias with sort of a similar underlying pathology. But frontotemporal dementia is different from, say, Alzheimer's disease in that it tends to occur earlier in life, and there's one variant that I'll talk about today called the behavioral variant. And I think before we dig into what that actually is, we need to take a step back and talk about the frontal lobes, which is the area of the brain that's disrupted in frontotemporal dementia. So the frontal lobes conveniently are located in the front, makes sense. And this is the part of the brain that really makes you, you, okay? We've got inputs to the frontal lobe that are touch and hearing and visual and emotion, you name it. It all gets fed into the frontal lobes, and it all gets associated together, and then the output is really what makes you, you, as cliche as that sounds. The frontal lobe is absolutely critical for motivation, for social inhibitions, for planning, for executive function, for logic. You name it, it's coming from the frontal lobes. So obviously it's an area that's dysfunctional in frontotemporal dementia, and we'll dig into that in a minute, but I think it's important to remember what the functions are of the frontal lobes, because when there's dysfunction of the frontal lobes, all that can go wrong. All right. There's a classic story that you've probably all heard of in Psychology 101, and it gets told a lot when we're talking about frontal lobe dysfunction. And it's about Phineas Gage, who I think it was in the 1800s. He was a miner, and his job was to tamp down sticks of dynamite. So basically the way that they were mining, they would drill a little hole into the side of a big rock or a mountain, put a stick of dynamite in, and then take the tamping rod and tamp it down before it exploded so that they could get, access to more rocks. And poor Phineas, I don't know if he just misgauged or miscalculated the length of his fuse, but the dynamite exploded before his tamping rod was out of the hole. And so that caused the tamping rod to go straight through his head. Now, the amazing part is that he survived. This is more than 100 years ago. It would be amazing to survive that now in 2019, but especially back then. But from anyone that knew Phineas Gage before the accident, they would tell you he was the nicest guy in town. He'd give you the shirt off his back, just a real good guy. After the accident, he turned into Ebenezer Scrooge. He was a mean person, a grouch. He was the complete opposite of what he was beforehand. Now, it's not because I guess if I had a rod that went through my frontal lobes, I probably wouldn't be too happy about it. But it's not that he was willfully becoming this grouch. It's because his frontal lobes, the area of the brain that's important for Phineas, for his intrinsic Phineas, were, basically skewered. So in frontotemporal dementia, we can have a similar issue. I can't count the times where I've sat across the table from husband and wife, and the wife says, yeah, he used to be so motivated, he was always productive, and now he's just content to sit on the couch all day. TV doesn't even have to be on. He can just sit there all day and do nothing. Or the complete opposite of that, the candy jar or candy dishes on the table, and he just can't keep his hands out of the candy dish. He's always going after the candy. Or when we go out into public, he's saying obscenities or groping people in public, something that's totally unacceptable from a social setting and totally different than who he was before symptoms started. So you can imagine that, one, if you didn't know that an individual had a disease, that it'd be very difficult to view that as anything other than a change in personality. How could a person do that? But even after someone's diagnosed with these diseases, it can be really difficult to remember that it's not the person willfully doing these things, it's the disease. And it's even harder to respond appropriately to that because, as a loved one of someone with, say, frontotemporal dementia or any kind of neurodegenerative disease, we want to interact with our loved ones, and unfortunately, so many of these diseases rob our ability to do that. The other reason that I brought my daughter on camera is because I want to kind of illustrate how frontal lobe dysfunction can cause symptoms. Okay, so I'm going to talk to you about reflexes. Now, you've all gone to the doctor and had your patellar reflex struck, and you provide an input, which is striking the patella, and then your leg kicks up. And so that's essentially what a reflex is. You provide an input, and then there's an automatic response, something that you don't voluntarily do, in response to that sensory input. So we have other reflexes that, beyond just tapping with a reflex hammer, that can do the same thing. And so I'm going to get my assistant here, and she's nice and awake and maybe a little bit cranky. And hey, baby girl. Hey, baby girl. This is your debut, sweetheart. Hey. You're losing your hat. We'll just take that off there. Okay, so we're going to use the pacifier. And first reflex that I want to show you is if I touch the side of her mouth, I just touch it, she orients. She tries to go to that pacifier and she'll just chase it around. That's called the rooting reflex. And then if she finally gets to it, obviously everyone knows that the baby's going to start sucking on the pacifier. So those are two reflexes that are present at birth. And there are many other reflexes that are present at birth, and we refer to a lot of these as primitive reflexes. Now, as we get older, not even that much older than she is, so those reflexes start to go away. And that's largely because our brain is developing in a way that suppresses them. And a lot of that comes from the frontal lobes. I'm going to set you back down, sweetheart. From our frontal lobes. And just the same way that our personality could change if our frontal lobes are damaged, some of those reflexes can come back. So yeah, actually you can have an adult that has reemergence of the rooting reflex or the suck reflex and several others as well. So it's not that it's not that they have any control over that. It's a reflex. It's something that's directly due to brain pathology. It's directly due to the disease. And in the same manner, the personality changes that come along with frontotemporal dementia or the memory changes that come along with Alzheimer's disease aren't anything other than the disease process, okay? So try to remember that if you have a loved one with one of these diseases, and if you're faced with a difficult decision, a difficult situation, a difficult interaction with one of them, try to take a step back and take a deep breath and remember that if you're hearing something that you just know is not who that person is, it's not who that person was before the disease, you're right. It's the disease. So take a step back and try to handle the situation with compassion.
Thanks for tuning in again for another episode of my YouTube channel, Long Live the Brains. If you'd like to see more videos like this, then subscribe to my YouTube channel and also click the notifications bell so that you're notified every time I upload a new video. The content for these videos is based on your feedback. So if you liked today's video, click the thumbs up icon or post a comment with questions or suggestions about future topics you'd like to see. I want to know what you want to know. Now, I'm also on social media at Twitter and Instagram at Philip Tipton MD, and you can go there to find more neuroscience related content. Thanks for watching and have a great day.